Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In episode 2 of this 2-episode series, we ask the question, should quantitative hepatitis B surface antigen testing be used routinely in clinical practice for patients with chronic hepatitis B? Joining us are Dr. Paul Kuo from Stanford University School of Medicine, Dr. Tatyana Kushner from Icahn School of Medicine at Mount Sinai, and Dr. Ira Jacobson from NYU Langone Health. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear Dr. Kushner describe the use of quantitative hepatitis B surface antigen testing, as well as other biomarkers in clinical practice.
So why do we need additional biomarkers? So we have our HBV DNA, we have our ALT, we have these other virologic biomarkers, but really these biomarkers have limitations in predicting true clinical outcomes, as we'll see, particularly in certain subpopulations. Really, our gold standard, what we would like to do is to assess cccDNA, and that would give us an understanding of the full understanding of HBV replication and transcriptional activity. But to get at that, it really would require potentially invasive procedures, and we need novel biomarkers that can act as a surrogate that measure cccDNA. And that's where quantitative surface antigen enters the picture. So quantitative surface antigen, so that's quantitative, meaning you're able to detect the level of surface antigen as opposed to binary reactive or not. It is an assay that's available from different diagnostic companies. There's a World Health Organization international standard for it. And it is a marker of transcriptional activity of cccDNA. There are important nuances to know about it because actually it detects all 3 forms of circulating hepatitis B surface antigen, and does not always correlate with viral replicative activity because not only does it reflect cccDNA, but it also reflects surface antigen expression from integrated HBV DNA. And generally we think of more integrations occurring in e-antigen negative patients. And so we see that this becomes really an important marker, in particular, as I'll demonstrate later, in e-antigen negative patients who have more integrated DNA. And surface antigen levels fluctuate during the hepatitis B disease course, but earlier we mentioned that hepatitis B DNA levels really fluctuate on a very consistently, and it's not a very static level. So even on a week-to-week basis, HBV DNA levels may be different. Surface antigen is a little bit more stable, and that's one of the reasons why quantitative surface antigen can be beneficial, because it's a more stable marker of disease. And it varies in terms of level depending on where you are. So acute hepatitis B patients tend to have higher levels of surface antigen, whereas in chronic hepatitis B, the majority are less than 4 logs in over 90% of people. And we've learned over time the hepatitis B surface antigen quantification gives us a better idea of who truly is an inactive carrier of hepatitis B. We've learned that in patients who have surface antigen titers of less than 1,000, they are much more likely to be inactive carriers. And furthermore, hepatitis B surface antigen titers less than 100 increases the specificity of identifying these inactive carriers, but reduces sensitivity. So these 2 numbers are numbers that are kind of recurring themes in many of the studies that look at quantitative surface antigen, the 100 cutoff and the 1,000 cutoff. So what can we use it for potentially in clinical practice? Well, I think it really can be used to individualize our approach in our discussions with our patients, because really it provides more data on the disease state and prognosis. So it has prognostic value. It can really identify true inactive hepatitis B carriers, so that can inform your decision potentially about who's inactive and who you may consider potentially stopping treatment, or who you may avoid starting treatment because they're inactive. Also, it can be used to monitor response to treatment. So we've seen this in patients on pegylated interferon. So it can provide an early stopping rule in patients who are not responding, or it can provide a prognosis in terms of who is more likely to respond if you can monitor the surface antigen titers. And again, this is particularly relevant to pegylated interferon that has more of an effect on surface antigen titers than nukes and nucleotide analogs, but will, as we'll demonstrate, have even more relevance in the new drugs that are being developed. And surface antigen titers can predict surface antigen loss. So if you have low surface antigen titers in certain individuals, then you may counsel them that they may be more likely to have functional cure. They may have surface antigen loss. Quantitative surface antigen does provide additional data on inactive hepatitis B status and prognosis, in particular among those E antigen negative patients that are in the gray zone. Quantitative surface antigen can be a valuable tool when evaluating patients in the gray zone to really determine if they're true inactive carriers, and in that context can really help inform the treatment decision, whether you decide to offer treatment or whether you say, actually, you're an inactive carrier and you may do well without treatment. It has prognostic value. It can inform those discussions when patients perhaps are worried about treatment or don't really see the benefit of treatment. You can look at the quantitative surface antigen to share data with them about their potential increased risk of HCC and cirrhosis development. An informed discussion with the patient can include the result of a quantitative surface antigen to really help with this joint decision making in order to determine who needs to be treated, but also if they want to stop treatment, to inform the discussion of potential risk of flare and or the durability of response long term. And I think really as we study the new drug mechanisms that work specifically or indirectly on surface antigen reduction, quantitative surface antigen measurements really become a critical part of monitoring and treatment assessment.
So let's just talk a little bit about just this quantitative surface antigen, which is a biomarker. Tatyana, do you think we have all the biomarkers that we need now, or do you think we're evolving to using quantitative surface antigen? What are some of the other biomarkers that you think are probably going to be helpful moving forward to help us best counsel our patients and guide treatment decisions?
Yeah, I think reviewing the literature on the quantitative surface antigen, it really did bring to my attention that what we have now is not sufficient. And in particular, this idea that the HBV DNA really just fluctuates a lot and we're not getting an accurate picture of the chronic disease state. And that in certain subpopulations, actually the surface antigen does better, quantitative surface antigen does better than the HBV DNA. So I do think that there's a role for additional biomarkers. I think the quantitative surface antigen is ahead of the other ones, and it is available. So I think if we start somewhere, we should start with this. But there are also others that are being investigated, but more in the research context.
Yeah. With regard to hepatitis B surface antigen, Ira, comes from two sources.
Right.
And one of the, especially as when it gets down, is surface antigen levels can get lower with treatment. How do you think, what are the assays, if you could design your ideal surface antigen assay, Ira, that you could share and help guide, what would that consist of? Your report, say you're seeing it as a report.
Well, without making any claim to having any of the knowledge about how to design the assay, I know what assay I would design or engage with scientists to design.
Yes.
And there are many attempts going on right now. So the essential biological message here is that starting with observations that I believe came from the Arrowhead siRNA study, first in chimps, the discovery has now become commonly known that in E antigen positive patients, most of the surface antigen is coming off the cccDNA, which is obviously transcribed into messenger RNA and so on. And in E negative patients, much or most of it, depending on the patient, obviously there's some range, comes from the integrated DNA. Because when the viral genome is inserted, it's only inserted in terms of only the S portion of the genome. And according to some data, the X portion, but not the rest. There's no whole genome. It's not like retrovirus and provirus with HIV, where you can read off whole genome from integrated genetic material. But the S protein is certainly read off the integrated DNA, and that is preponderant, it seems, in E-negative patients. And they're not quite the same. I only get this from the scientists who I listen to and the papers that I read. I'm not a laboratory person. But if we could devise assays to distinguish between the two, and again, there are many efforts underway, this would be a major step forward in the field. Because what we want to know as we develop our novel agents, and of course there are many such classes, we want to know whether we're making the greatest inroads against CCC-derived DNA, HBsAg, or integrated derived HBsAg, coming from integrans as they're called. That might actually define what success means. The concept has now become prevalent that we might one day have to settle in patients, most of whose SAG was coming off integrated DNA, with eradicating all the cccDNA, making reactivation impossible and thereby enabling patients to get off therapy, but might have to settle conceivably, at least conceptually, with the patients being eternally HBsAg positive, because we don't know how to get rid of integrated DNA. And therefore, we don't know how to get rid of the S antigen read off of that. Now, of course, in the clinic, some patients who are E negative do clear SAG, and we just don't understand the dynamics of what's going on. So it's become a very, very important concept. I can't sit around a table with people developing novel drugs nowadays where this discussion doesn't regularly come up.
Agree. So, Tatyana, if you get a call from a colleague and they say, hey, I have a patient in my office, they stopped their nucleoside or nucleotide, I got a quant surface antigen and it was 100. What do I do? What advice do you think you would give somebody like that? And let's first start off with somebody, let's just say they're Asian first, and then we'll change it to whether or not they're Caucasian.
Right. Yeah. So first, I would tell them that if they're ordering a test, they should know what to do with it. But first things first. But so, when I showed that surface antigen titer less than 100 is associated with more durable response, less likely risk of post-treatment cessation flare. So I would say that if their surface antigen titer is less than 100, then it is okay for them potentially to monitor them. I would still say monitor them closely, but hopefully they could be okay off treatment. I think to our earlier discussion that their surface antigen titer is so low, perhaps if they stayed longer on treatment, then maybe they can fully clear it and it can predict functional cure. So that would be the other perspective of, well, maybe then yes, continue treatment. But I think I would be more reassuring to that provider to say that, well, if the surface antigen titer is low, then it should be okay that the patient stop treatment.
And then how do you counsel to monitor these individuals if that happens in your own practice? How are you doing that? Have you had patients stop, maybe not with a quant surface antigen?
Right. Yeah. So I think I rarely stop treatment. I'm worried about flares. But if I do stop treatment, then I definitely monitor them more closely than others. So I would really be checking their viral load and liver tests and perhaps quantitative surface antigen at least on a every 3-month basis, perhaps even sooner after that initial discontinuation to make sure that there's no flare.
Great. Thank you so much. Ira, if you do sit down with somebody who's in the so-called, we'll use the term immunotolerant that you used in your presentation, how do you follow these individuals once you initiate therapy? Do you follow them differently than you do others, or is it the same algorithm?
Yeah, pretty much. I follow them every 6 months. I get a viral DNA. I get periodic HBsAgs to see if they've cleared. Of course, the immune tolerance generally won't, and you have to prepare them for that. My last patient did clear after 10 years. I took credit for it, even though he might have done it on his own. He was very happy. No, I don't really change the algorithm very much. Okay. And I do screen them for liver cancer if I can be so bold as to be a little controversial, even though they're under 40. Okay. So every once in a while, you'll see that.
Sure. And we need better biomarkers there, too, for hepatocellular carcinoma. There's no question. I mean, what we use AFP and ultrasound now, better biomarkers there will be just really help us reduce the incidence of HCC. Now, if you clear e antigen in your immune tolerant patient, Tatyana, do you consolidate and then stop? Do you have a discussion about continuing after a period of consolidation? I know the guidance says we consolidate and stop 1 to 3 years is best, but some of us and some also continue treatment onward.
Yeah, I honestly haven't had too many patients that have seroconverted. I've had a few, and I think that, speaking also with other providers, even if there's seroconversion, there's really a lot of hesitation to stop because, again, the worry for flare and seroreversion also. But I am thinking one patient in particular that I met during pregnancy. She was e-antigen positive, then she seroconverted postpartum, and she really, 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 even from the time of pregnancy, did not want to be on treatment. And then when she seroconverted and I waited for a year, I said, we can consider it. And so we did. We did stop treatment. She actually did fine. I monitored her very closely. I was very nervous, but she did have low-level viremia, but she never seroreverted, and she didn't have any kind of clinically significant flare.
Paul, if I could comment, to me, it's not a question of the immune tolerance versus the others. I think maybe the question for me is, what do you do in general with your E antigen positive patients who clear E or seroconvert with appearance of the E antibody?
So what do you do?
So I'm a 3-year person. There is some literature. Harry Jansen had a paper a few years ago suggesting that if you stop after a year, you'll get a little more reversion than if you wait 3 years. The guidelines don't say that. They say at least 12 months. But I take it out further, and I would do the same thing for an immune-tolerant patient versus somebody else who was E-positive when they started.
And then you stop your therapy and observe them.
Yes.
So I will I offer to continue treatment even if you've cleared E antigen.
Indefinitely?
Yeah.
Do you have that discussion with the patient and tell them? And you say,
I say, here are your options. We can consolidate. You can stop now. There will probably be some viral rebound, or we can continue to move forward. And many choose to continue, particularly younger people. Again, we've talked about some of the stigma. They like knowing that they're going to be HBV DNA long term, but we need more data in this area.
Can I bring something up, Paul? Would you forgive me? This inactive carrier term bothers me a little bit. Is it a biological term, or is it a term that we're using operationally in the context of a practice to make practical decisions based on clinical outcomes? You showed, Tatyana, that between 100 and 999, the relative risk of HCC was 2.3 to 3.2-fold, those with lower than 100.
Right.
That doesn't sound like a great idea to me in terms of if you're using it based on clinical outcomes. And yet they're clearly not inactive because they do have some virus and they have. So what are people talking about in the literature when they use this phrase inactive carrier? Is it biology or is it a clinical outcomes term?
I mean, I think for the most part, they're trying to assess the viral picture at the moment and say, is there histologically, there does not appear to be any inflammation, HBV DNA is low, and theoretically, well, not theoretically, but data shows that long-term prognosis-wise, they'll do better or do well in terms of HCC risk and cirrhosis. But I do agree that who's truly inactive, and perhaps it is these additional biomarkers that we need, maybe not even just quantitative surface antigen to really get at the truth. And of course, we're not really doing biopsies on any of these patients anymore. So the histology is not really part of the picture for the most part.
And just to go to your point, Ira, I actually think quantitative surface antigen will be very helpful in these indeterminate patients. And you wonder in some of the data you showed, and we've seen where we get outcomes that aren't good, like HCC, whether or not these are individuals who will turn out to have higher surface antigen levels. And we maybe a priori might be able to identify these individuals. More studies yet to come.
I really like the way Tatyana intercalated that quantitative HBsAg question mark into the picture of the guidelines.
Yeah.
Saying that might help decision-making in some of these gray zone patients.
Yes, that's exactly right.
Yeah.
That was very well done.
I'd like to thank Dr. Jacobson, Dr. Kushner, and Dr. Kuo for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on time to move the goalposts, examining strategies to advance HBV management on the Clinical Care Options website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.